Now let's dive into part 3, valvular heart disease and endocarditis. We are looking at the failing doors. This isn't just pure pathology, we will be heavily integrating microbiology, immunology, and clinical medicine. Your heart beats about 40 million times a year. What happens when those hinges fail? There are 3 main mechanisms of failure we will cover today. First, wear and tear, which gives us degenerative disease. Second, the autoimmune mistake, primarily rheumatic disease. And third, the bug attack, which is infective endocarditis. Let's start with the first mechanism, degenerative disease, specifically calcific aortic stenosis or the stiff door. Look at the normal 3-leaflet valve compared to the calcified valve. Constant mechanical stress over decades leads to stiff calcified leaflets. To force blood through this narrow opening, the left ventricle undergoes concentric hypertrophy. I want you to remember this age cheat code. If the patient's age at presentation is in their 70s or 80s, you are looking at senile calcific aortic stenosis. This is a normal 3-leaflet valve that has simply worn out over a lifetime. However, if the patient presents in their 40s or 50s, suspect a congenital bicuspid valve. This affects 1 to 2% of the population because 2 leaflets are taking the stress meant for 3. The valve wears out 20 years early. Finally, for your clinical presentation, remember the mnemonic AS makes you sad. S stands for syncope, which is fainting on exertion. A stands for angina, because that hypertrophied heart needs more oxygen. D stands for dyspnea, indicating heart failure. Sticking with degenerative disease, let's look at mitral valve prolapse, or the floppy parachute. In a normal mitral valve, a strong collagen layer prevents blood from flowing back into the atrium during a contraction. In mitral valve prolapse, the valve prolapses backward into the left atrium during the ventricular squeeze. The pathology behind this is called myxomatous degeneration. The strong collagen is replaced by loose, spongy proteoglycans. Note the strong genetic link. MVP is highly associated with Marfan syndrome, which is a defect in the fibrillin 1 gene. Classically, the classic sign you will hear on auscultation is a mid-systolic click followed by a late systolic murmur. Moving to our second mechanism, the autoimmune mistake or rheumatic fever. It begins with the trigger group A streptococcal pharyngitis. The focus here is that the bacteria displays an M protein. Next is the confusion. Your immune system ramps up and creates mass antibodies targeted specifically against that bacterial M protein. This leads to the attack caused by molecular mimicry, which is a type 2 hypersensitivity reaction. The antibodies mistakenly attack structurally identical human glycoproteins in the heart valves, joints, and basal ganglia. Ultimately, the immune system gets confused and attacks you. During acute rheumatic fever, we see pancarditis, meaning all layers of the heart are inflamed. Let's break them down. In the pericardium, the outer layer, we see pericarditis. This is characterized by a fibrinous exudate, famously known as the classic bread and butter pericarditis. In the myocardium, the middle layer, we see myocarditis. This is the killer in the acute phase. It features the pathognomic Escoff body, which is an area of fibrinoid necrosis. Inside, you will find Anitzkow cells, which are modified macrophages with wavy chromatin, affectionately known as caterpillar cells. In the endocardium, the inner layer, we see endocarditis. This presents as 1 to 2 mm warty, sterile vegetations located strictly on the lines of closure. The resulting regurgitant jets create rough fibrous scars on the atrial wall known as McCallum plaques. When that acute inflammation heals, we get chronic rheumatic heart disease. The gross morphology of this healing shows thick scars and fused chordae. This creates the classic fish mouth or buttonhole stenosis you see in the image. Remember, this process causes 99% of mitral stenosis cases. To diagnose rheumatic fever, you need evidence of a prior strep infection like an ASO titer plus the major criteria. Use the mnemonic Jones. J for joints, migratory polyarthritis. O looks like a heart standing for carditis. N nodules, subcutaneous and painless. E for erythema marginatum, a red ring-like rash. S for Sydenham chorea, rapid involuntary dancing movements from the basal ganglia attack. Now for our third mechanism, the bug attack or infective endocarditis. We classify this into acute and subacute. Acute endocarditis. The bug is Staph aureus, which is highly virulent. It attacks a healthy normal valve. The classic patient is an IV drug user because bacteria are injected straight into the veins and hit the tricuspid valve first. The morphology shows massive, bulky, friable vegetations that destroy the valve, causing perforations and ring abscesses. Subacute endocarditis. The bug is Strep viridans, which has low virulence and is normal mouth flora. It attacks a previously damaged valve, like one with old RSD or MVP. The classic patient history is someone with a bad valve who had recent dental work. The bacteria slowly stick to existing scars, making it much less destructive than the acute form. The clinical signs of infective endocarditis are a mix of systemic emboli and immune complexes. Remember the mnemonic from Jane. F and M, fever and new or changing murmur. R, Roth spots, which are immune complexes in the retina. O, Osler nodes, which are painful, raised immune complexes. J for Janeway lesions, which are painless septic emboli. A is for anemia of chronic disease. N for nail bed hemorrhages, also known as splinter clots. And E for emboli, which can cause a stroke in the brain or infarcts in the kidney. This slide is your master synthesis, preparing you for the Viva trap regarding the 4 types of vegetations. Rheumatic heart disease, visually these are small and sterile, located strictly on the line of closure. The clinical association is post-strep or autoimmune. Infective endocarditis, these are large, bulky, infected and destructive, and they embolize easily. The clinical association is a bacterial infection like S. aureus or S. viridans. NBTE or merantic. These are small, sterile, and loosely attached to the line of closure. The clinical association is hypercoagulable states or Trougeot syndrome, often seen with pancreatic cancer. And last, Libman sacs. Crucially, these are located on both sides of the leaflet, top and bottom. The clinical association is systemic lupus erythematosus, SLE. Congratulations, you have conquered the walls. You have mastered the molecular immunology of rheumatic fever, differentiated the acute microbiology of infective endocarditis, and locked in your clinical diagnostic mnemonics like SAD, Jones, and from Jane.